mentioned at the end of this session, it is my goal that you will be able to recognize asthma in children, distinguish the different medications used to treat asthma, as well as formulate a long-term management plan for asthma. I will not go into the management of status asthmaticus or acute asthma exacerbations. So it is estimated that as many as 300 million people of all ages and all ethnic backgrounds suffer from asthma, with about 250,000 deaths per year. This is a world map of the prevalence of asthma based on two large multinational studies, one done in adults and another one done in children. So the red countries are those with higher prevalence, and we can see the United States, Canada, United Kingdom, Australia among those countries. The Philippines has an estimated prevalence of asthma of about 5 to 7.5%. Now, asthma prevalence here in the United States has shown an increasing trend from 7.3% in 2001 to 8.4% in 2010. More recent statistics, however, appear to be a little bit more encouraging since we see a little bit of a drop in the prevalence of asthma in children. So asthma affects about 1 in 11 children. Approximately 9 people die from asthma each day. In the United States, pediatric asthma was responsible for 200,000 hospital stays in 2009, as well as 3.5 million doctor visits. More than 650,000 emergency room visits, with 1 out of 5 children with asthma needing to go to the emergency room. More importantly, almost 1 in 2 children with asthma miss at least 1 school day per year, and about 3 in 5 children limit their activities because of asthma. Now, asthma varies greatly in severity. Some children may just have mild symptoms or may respond well to asthma medications, while some may suffer more serious attacks. This graph is from a study of 51 pediatric asthma deaths in Australia. On the x-axis is the asthma severity, and on the y-axis is the percentage of deaths. Note that even children with a mild degree of asthma are at risk. So what is asthma? Asthma is a chronic inflammatory disorder of the airways, usually associated with hyperresponsiveness in response to triggers, leading to airway obstruction that is usually fully reversible, either spontaneously or with treatment. And it is this airway obstruction that leads to the classic symptoms of asthma, including cough, wheeze, and dyspnea. Asthma is a heterogeneous disease with different underlying disease processes. So this photomicrograph on the left shows a normal human airway respiratory epithelium with a airspace up here, pseudostratified respiratory epithelium right here, and a rather bland submucosa. This shows the airway inflammation in asthma with numerous inflammatory cells in the submucosa, thickening of the basement membrane, and denudation of the epithelium. So asthma has been known to lead to significant structural airway remodeling, as shown in this part of the slide. So there's mucus hyperplasia and hypersecretion. There's thickening of the basement membrane, as well as an increase in muscle volume. Now, asthma is a clinical diagnosis. There is no single diagnostic test for this condition. In children 6 years and older, a diagnosis of asthma is made based on a history of a characteristic pattern of respiratory symptoms, as well as evidence of variable airflow limitation. These are the patterns of respiratory symptoms that are characteristic of asthma. So typically there is more than one symptom: wheezing, cough, shortness of breath, chest tightness. These symptoms are often worse at night or in the early morning, and this is because lung function is worse during this time of the day because of the circadian pattern of secretion of hormones. These symptoms usually vary over time and in intensity and are typically triggered by exercise, allergen exposure, changes in weather, laughter, and irritants. Symptoms often appear or worsen with viral infections. Now, in asthma, expiratory lung function varies over time and in magnitude, and this can be documented through several ways. So an easy way to do it at home is to monitor peak flows and to demonstrate excessive diurnal variation in peak flows. documenting airflow limitation, and in spirometry, what we're looking for is evidence of a low FEV1 over FVC ratio. So in children, normally they have FEV1 over FVC ratios of more than 90%. We say the child is obstructed if the ratio is less than 85%, some say less than 80%. Variability can also be demonstrated in spirometry by showing the response to bronchodilator. A significant response to bronchodilator is an increase in FEV1 of at least 12%, as seen in this example. So before bronchodilator, FEV1 was 64% predicted. After bronchodilator, FEV1 was 82% predicted, an increase of 27%, which is very significant. Now, in younger children, those less than 5, the diagnosis of asthma may be a little bit more challenging, especially since episodic respiratory symptoms such as wheezing and cough are common in young children without asthma, particularly those in the 0 to 2 years age range. Some practitioners may be even hesitant to give a young child a diagnosis of asthma until they reach a certain age. Some do not give a diagnosis before the age of 1, others do not give a diagnosis before the age of 2. It is also not possible to assess routine airflow limitation during evaluation in young children. So a diagnosis of asthma in young children, therefore, is based largely on symptom patterns, and this should be combined with a careful clinical assessment looking for the presence of risk factors for the development of asthma, and in some cases, even looking at the therapeutic response to asthma therapy. Features suggesting a diagnosis of asthma in children less than 5 years of age include the following. So cough, which is usually non-productive, is recurrent or persistent. It is typically worse at night and may be associated with some wheezing and shortness of breath. Cough occurs with exercise, with laughing, with crying, with exposure to environmental tobacco smoke in the absence of respiratory tract infections. Wheezing is also recurrent, including during sleep, and also occurs with trigger. The same is true with difficult or heavy breathing as well as shortness of breath. They're all triggered either by exercise, by laughing, or by crying. Some children may manifest with just reduced activity, not running, not playing, not laughing as hard as other children, and some kids just tire earlier and just prefer to be carried. Other evidence of atopic disease in the child, including eczema, as well as a family history of asthma in a first-degree relative, both suggest asthma. Now, finally, as there are no tests that can diagnose asthma with certainty in children 5 years and younger, a therapeutic trial lasting 2 to 3 months with as-needed short-acting beta agonist and low-dose inhaled corticosteroid may help in the diagnosis. Now, if a therapeutic trial is done, clinical improvement during the 2 to 3 months of treatment is shown, and there is worsening once the treatment is discontinued. Other tests that can be done include tests for atopy as well as FeNO. So FeNO, or exhaled nitric oxide levels, can be done in children as young as 1 year of age. FeNO is elevated in eosinophilic inflammation, and it can also be used to determine corticosteroid responsiveness as well as adherence to steroid therapy. It can be used to support a diagnosis of asthma in young children. Our cutoff points are the following. So a high FeNO of 35 parts per billion or more in children suggests eosinophilic inflammation and possible corticosteroid responsiveness, while a low level suggests that eosinophilic inflammation and corticosteroid responsiveness are unlikely. Now, this figure helps with determining which among these kids, 5 years and younger, may have asthma. So this takes into consideration those kids with frequent respiratory tract infections who cough. This symptom pattern may vary over time, but those kids who tend to have the symptoms more on the left side, so the symptoms last for less than 10 days. During upper respiratory tract infections, only 2 to 3 episodes per year, no symptoms between episodes, are less likely to have asthma compared to those who are on the other side of this graph, those with symptoms more than 10 days of duration, more than 3 episodes per year, and having having symptoms between episodes, as well as having a family history of atopy and asthma. So the differential diagnosis of asthma is broad. We like to refer to them as mimickers and contributors, as some of these conditions may coexist with asthma. So among children older than 6 years of age, chronic upper airway cough syndrome is a common cause of cough. So chronic upper airway cough syndrome is basically defined as just cough associated with upper airway conditions. So these upper airway conditions may include allergic rhinitis, non-allergic rhinitis, sinusitis. And as we know, allergic rhinitis may coexist with asthma. In younger children, again, it is the recurrent viral respiratory tract infections that are common differential diagnosis for asthma. Gastroesophageal reflux may cause asthma-like symptoms by means of 2 mechanisms, one either through vaguely induced bronchoconstriction, through reflux with aspiration and inflammation. So a common question that we get from parents in clinic is, will my child outgrow asthma? So there is no cure for asthma, but children can and do experience complete remission from this disease more frequently than adults do. So studies on the natural history of asthma and wheezing during the first 6 years of life identified 2 groups of children with wheezing and asthma symptoms. So the first group has intermittent symptoms at an early age, usually in relation to a viral illness. These kids typically outgrow their asthma such that those with symptoms during the first 3 years of life, by the time they are 6, about 60% of them are asymptomatic. The other group is those with later onset and persistent symptoms, and usually these children have a history of atopy and a family history of asthma. Now, these kids are at an increased risk for asthma later in life. Now, it is estimated that about 30 to 70% of children who develop asthma later in childhood improve or are asymptomatic by early adulthood. The predictors of persistent asthma among these children include, again, a history of atopy, high airway responsiveness, and low lung function. So asthma, when it develops early in life, may be associated with deficits in lung function that are persistent and can be detectable throughout childhood. Now, can asthma be prevented? There are some risk factors that have been identified to increase the risk for asthma. Some are non-modifiable, sex, family history, genetics, while there are some that can be modifiable, including smoking, the use of antibiotics during the first year of life, certain infections which are vaccine preventable, and obesity. So the goals of asthma management are twofold. First is to achieve good control of symptoms and maintain normal activity levels, and second is to minimize future risk of exacerbations, fixed airflow limitation, and side effects from treatment. So the Global Strategy for Asthma Management and Prevention, or the GINA report, uses a control-based asthma management. In a control-based asthma management, pharmacological and non-pharmacological treatment are adjusted in a continuous cycle that involves assessment, treatment, and review. And these are the different factors in each of these. Symptom control is assessed by frequency of asthma symptoms, night wakings due to asthma, and need for reliever medications, as well as any activity limitation, and may be rated as either asthma that is well controlled, partly controlled, or uncontrolled. Control of risk factors is very important. From a practical standpoint, asthma control, for me, entails no acute episodes requiring urgent care, no absence from school or activities, no missed time from work for caregivers, no sleep disruption, normal or near normal lung function, and medication that is well tolerated with minimal, if any, side effects. So asthma treatment is composed of pharmacotherapy, of non-pharmacological strategies, and of treating modifiable risk factors to reduce exacerbations. So non-pharmacological strategies and treating modifiable risk factors, some of them are in this slide, but I will focus more on the pharmacotherapy that we use for asthma. So in the past, this was what was used for asthma. This is actually here, asthma cigarettes, Asthmador cigarettes. I don't know what they contain. It looks like it's like a belladonna compound. But asthma pharmacotherapy, there are 3 types of medications for the long-term management of asthma. So we have the rescue or reliever medications, the controller medications, and the add-on therapies for severe asthma. So under the rescue medications, we have the short-acting beta agonists, which have a very quick onset of action within 3 to 5 minutes, but the effects last for only 4 to 6 hours. They can also be used to prevent or reduce the symptoms that are known to be caused by certain conditions such as exercise. Now, the frequency of the need for short-acting beta agonists is used to gauge asthma control. Now, among the controller medications, the inhaled corticosteroids are the most effective class. So no other class of asthma medications can lead to reduction of symptoms, to improvement of lung function, to decrease in airway hyperresponsiveness, prevention of exacerbations, and possible prevention of airway remodeling to the same degree as inhaled corticosteroids can. So looking at the older studies on inhaled corticosteroids, so this shows the change in lung function with budesonide therapy compared to placebo. So these are different doses of budesonide, and as you can see, with higher doses, the improvement in lung function is greater, although in the highest doses, there seems to be like a plateau in the effect. In terms of looking at the airway, so this is a bronchial biopsy of a patient with asthma before and 3 months after treatment with budesonide, showing normalization of the epithelium and absence of the inflammatory cells, which are very prominent in this on the left side of on this figure. Inhaled corticosteroids also help prevent asthma-related hospitalizations. So this study looked at beta agonist prescriptions compared to inhaled steroids, as well as the relative risk of hospitalization. So this study showed that on patients receiving just beta agonists, once they reach 2 to 3 prescriptions per year, the relative risk for hospitalization increases almost exponentially. However, those who are on inhaled steroids, even with the increase in number of prescriptions of beta agonists, there is no increase in the relative risk for hospitalization. So inhaled steroids are very effective anti-inflammatory agents. They are usually well tolerated. We do know that the safety of inhaled corticosteroids is greater than that of oral glucocorticosteroids, and not all inhaled corticosteroids are alike. They may be associated with side effects, ranging from minor side effects, such as oral candidiasis. There have been reports of hypothalamic pituitary axis suppression, as well as some growth effects. So it is very important to monitor patients' growth regularly and to step down on the dose if at all possible, and to even consider the addition of a steroid-sparing agent. However, some studies have shown that poor asthma control by itself can affect growth, with some studies showing that the effect of poor asthma on growth is worse than the effect of inhaled corticosteroids on growth. So what we do know in terms of the relationship between inhaled corticosteroids and growth, there is a slowing in growth velocity during the first year that a child is on inhaled corticosteroids. So they don't grow as much during the first year. However, there is no effect on the eventual adult attained height. Maybe they lose about 1.3 centimeters of adult height. So just taking things into perspective, you know, asthma can kill, but short stature never killed anybody. This was actually an editorial published in the Journal of Pediatrics when the effect of steroids, inhaled steroids on growth first came into light. So how do these inhaled steroids cause those side effects? We think it is through the systemic circulation, systemic absorption, of these medications. And systemic absorption occurs through two ways. So first is through the amount that is deposited into the oropharynx. So with an MDI, approximately 80% gets deposited into the oropharynx. This is swallowed into the GI tract, gets absorbed. Some get inactivated through the liver, and those that do not get deactivated are absorbed into the systemic circulation and lead to side effects. The other rest of the medication, about 10 to 20%, go into the lungs, and the lungs have a very large area for absorption. Depending on the inhaled corticosteroid, some of them may get absorbed into the systemic circulation, leading to these side effects. Now, there are several brands or several kinds of inhaled corticosteroids available in the market. They are available either as metered dose inhalers, as discus or dry powder inhalers, and as nebules. Now, the second group of controller medications are the long-acting beta agonists, and their effects last about 12 hours. They are considered controller medications. There are currently two formulations, formoterol and salmeterol. They have some difference in that formoterol is both a short-acting and a long-acting beta agonist. The short-acting component has an onset of 3 to 5 minutes and lasts about 4 to 6 hours, while its long-acting component has an onset of about 20 minutes, with effects lasting for 12 hours, which is the same with salmeterol. So looking at its effect, so this showed the change in peak flows with low-dose fluticasone combined with salmeterol, as well as high-dose fluticasone. So what they showed was that at all time points, the improvement in lung function was greater when salmeterol was added to low-dose fluticasone rather than just increasing the fluticasone dose itself. Subsequent studies have already confirmed that the addition of a long-acting beta agonist to inhaled corticosteroids as step-up therapy leads to better response to treatment therapy rather than just increasing the inhaled corticosteroid dose or even adding a leukotriene receptor antagonist. So long-acting beta agonists do come with a black box warning here, because of this study, which showed a slight increase in asthma-related deaths in patients receiving the drug versus those on placebo. So what we now do is that these medications should only be used as additional medications when the low dose to medium dose inhaled corticosteroids are not sufficient, or if the patient's asthma is serious enough to merit the use of two drugs. Long-acting beta agonists should not be used as a single agent, and in pediatric asthma, long-acting beta agonists should always be given with an inhaled corticosteroid. So these are some of the preparations available that we use in pediatrics. So I believe only fluticasone salmeterol is FDA approved up to 4 years of age, while budesonide formoterol and mometasone formoterol are approved for 12 years and older. So leukotriene receptor antagonist. Montelukast is an orally administered specific leukotriene antagonist. It has both anti-inflammatory and bronchodilator effects. It is useful in asthma, especially those in patients with comorbid conditions in which Montelukast also helps. So these are kids with allergic rhinitis, those with obstructive sleep apnea. They can be used as steroid-sparing drugs, meaning adding them can hopefully lead to some decrease in steroid dose. There are some risks, and there have been reports of behavioral changes with these medications. It comes as both tablets and granules. So this study just showed the effect of Montelukast on lung function. So this is placebo, and this is Montelukast. So there is improvement, significant improvement in lung function with Montelukast treatment. Now, for the most part, most children will be controlled with the standard therapies for asthma, including inhaled corticosteroids, long-acting beta agonists, and leukotriene receptor antagonists. However, there's a subset who do not respond or who continue to have severe exacerbations. And for those patients, there are some add-on therapies that can be used. And one of them is omalizumab, which is an anti-IgE monoclonal antibody. So this is the IgE molecule, which usually attaches to the mast cell or other inflammatory cells. And once that IgE molecule attaches to this mast cell, the mediators are released, leading to inflammation, leading to bronchoconstriction. What omalizumab does is it binds the IgE molecule such that the IgE molecule is not able to bind to the mast cell. So this is indicated for moderate to severe persistent asthma whose symptoms are not adequately controlled with standard therapy. Of course, they have to have a positive skin test or in vitro reactivity to a perennial airway allergen and should have an elevated level of IgE. Omalizumab has been shown to reduce severe exacerbations, hospitalizations, and emergency room visits. And has been shown to reduce corticosteroid dose by at least 50% and improves the baseline control of asthma and has a positive impact on the quality of life. Now, what studies are looking into now is the possible benefit of omalizumab on airway wall remodeling. Other add-on therapies include mepolizumab, which is newer, just got FDA approval in November. This is an interleukin-5 antagonist. So interleukin-5 promotes the production of eosinophils. So if you give this interleukin-5 antagonist, it reduces eosinophils, reduces inflammation, and leads to a reduction in severe exacerbations and the dose of inhaled corticosteroids. Tiotropium Bromide, another new drug, is a long-acting muscarinic antagonist, and it's been shown to improve FEV1 and reduce the need for short-acting beta agonists. So how do you decide which patient needs to go on a controller therapy? I like to use this rule of twos, very easy to remember. So I would say a patient would need to be on a controller medication for asthma if the child has at least 2 times per week or more of daytime symptoms, 2 times per month or more nocturnal awakenings, required 2 or more canisters per year of albuterol, and has 2 or more exacerbations in a year requiring oral steroids. Of course, there are exceptions to this. If you have one patient with just an exacerbation, but an exacerbation severe enough to end in the PICU, then I would say that child also needs a controller medication. So it's individualized, but I think these are very good guidelines for when to start controller medications. So this is from the GINA report showing the different steps. So asthma management is always stepwise, deciding if a child needs to be on controller medication would be here in step 2. Step 1 is basically just the use of the rescue medication. So first line of treatment is always low-dose inhaled corticosteroids, since we know that this is the most effective of all the controller medications. There are other options that can be used. And then step up is considered if the symptoms are not controlled, assuming that there's good compliance and good proper technique with the spacers and no other comorbid conditions. And then stepping down is considered once symptoms are improved. So we tend to monitor patients every 3 months to see if we can adjust any of their medications. The asthma control test is very useful in clinic. So this just basically is filled out by patients and their parents, looking at how they think their asthma is controlled over the past 4 weeks. And we use this as a guide as well, in addition to lung function, to decide if a patient needs a step up or a step down in therapy. Now for younger children, again, low-dose inhaled corticosteroid is the first line of treatment. If they need a step up, we usually double the dose or add a leukotriene. Referral to a specialist is earlier as compared to, this is for older kids, this is for 6 years and above. Step 3 is adding the long-acting beta agonist. Step 4 is increasing the inhaled corticosteroid. And step 5 is the add-on therapies that we talked about earlier. So in the management of asthma, it's not just pharmacotherapy. It is very important to provide guided self-management education. So we usually give patients nice asthma control plans, and then we look at possible risk factors at home. One big thing is smoking, and like I said, we consider stepping up if symptoms are not controlled. But first, we need to make sure that adherence, compliance is good, inhaler technique is good, and we have the right diagnosis. So this is just from a comic strip with showing the use of an asthma action plan. So one big thing with inhalers or with MDIs, so like I mentioned earlier, about 80 to 90% of the medication gets deposited in the oropharynx, only 10 to 20% gets into the lungs. So we can decrease this amount that goes into the oropharynx by using a spacer, or what is more properly called as a holding chamber. So how does a holding chamber do that? So it has to do with the particle size of the medication. So this graph shows the particle size here on the x-axis and the percent deposition. So this is deposition in the oropharynx, deposition in the bronchial and conducting airways, and deposition in the alveolar airways. So what we want is for the medication to be between in the alveolar and in the bronchial conducting airways, not in the oropharynx. We do see that once the size of the particle reaches about 5, most of it just gets deposited into the oropharynx. So what happens when you use a holding chamber is that the medication, as it travels through the chamber, decreases in size. It's mainly due to the loss of the propellant, and thus more gets deposited into the part of the lungs where we want them to go. So this is just comparing the size of the particles, CFC suspensions, which were used in the past, dry powder inhalers, the HFA suspensions, and the ultrafine particles. This is just an example comparing beclomethasone and fluticasone HFA deposition in the oropharynx and in the lungs. So since beclomethasone is much smaller than fluticasone, it does get more of the medication into the lungs as compared with fluticasone. So MDI withholding chambers for those less than or equal to 3 years of age, we do say that 1 puff into a chamber when a child is breathing quietly and allows 6 to 8 breaths. For the older child, at least 5 breaths or a 10-second breath hold. If using a mask with a holding chamber, we do recommend that it be tight-fitting, because we do know that with a loose-fitting face mask, the delivery of medication to the lungs is much less as compared to when the mask is tight-fitting. And this is assuming that the child is breathing quietly and not screaming or crying. A screaming or crying child has very little deposition in the lungs. So just to review how to use an MDI, so it first needs to be shaken, opened, attached to the holding chamber. Take a deep breath in and blow it out. Put the spacer in your mouth. Actuate the medication and take a slow, deep breath, making sure that the chamber does not whistle. So it has to be a slow, deep breath. And then hold your breath for at least 10 seconds. And then take a break before doing another puff. We don't recommend doing 2 puffs at the same time because that leads to less lung deposition, less drug deposition. With the dry powder inhalers or with the discus, the technique is a little bit different because they need to take a deep, rapid inhalation as compared to an MDI where you take a slow, deep inhalation, because they need to be able to aerosolize the dry powder in that medicine. So nebulizers may be used with face mask for those who are not able to use the mouthpiece. So the benefit is there's no need for inhalation or actuation coordination. However, the drawbacks, of course, it's very time intensive, and approximately 25% of the drug is left and never nebulized. So with nebulizations, we do want to transition to the mouthpiece as early as possible. Lung deposition tends to be better when using a mouthpiece. So here you can see the age here in the x-axis and the lung deposition, or the percentage of the nebulizer output. So in nose-breathing infants, deposition is very low. When a mask is used, nose-breathing children and adults, the deposition is a little better than infants, but it's much better when they use the mouthpiece rather than using a face mask. And this is because the nose is one of the great filters of our body. So I'd like to end by saying that when treating asthma, expectations should be high because symptoms can be controlled, the disease can be controlled, activity limitations are not necessary, and we can have just minimal to no adverse effects of medications. So the bottom line, asthma can be controlled at minimal risk. Thank you. And is there any questions?
Thank you, Dr. Melendres, for that very insightful and comprehensive lecture. I'd just like to welcome everybody again. And as of 12:30 p.m. Manila time, we have 37 attendees on live streaming and 91 on the GoToWebinar site. But before we proceed with the question and answer portion, let's have one of our panelists give her reaction. I would like to introduce Dr. Fatima Johanna Santos Ocampo. Joni, a graduate of UP College of Medicine, who did her residency in pediatrics at the Winthrop University Hospital, New York, and her fellowship in allergy and immunology at the University Hospital at Stony Brook, State University of New York. She is an active staff at the Makati Medical Center and Asian Hospital and Medical Center. Dr. Santos Ocampo.
Okay, good afternoon or early good morning, depending on where you are, my dear colleagues and listeners. I would like to thank Dr. Melendres for such an excellent review. In the wake of such an excellent lecture on the principles of asthma, diagnosis and management, I'm sure that all the listeners got a good dose of important updates on asthma. Now, for my part as an allergy immunology specialist, I'd just like to reiterate the role of atropine and increasingly altered immunology among at-risk patients, and this was mentioned in the lecture. And there is a lot to be said about the Airway Phenomenon. This describes the same inflammatory response occurring in asthma for the lower airways compared to that of the upper airway represented by allergic rhinitis. Citing the ARIA or the ARIA document, it is important to recognize the impact of allergic response to aeroallergens in particular on asthma severity as a risk factor and also its role in prevention of asthma itself. There are a lot of more studies showing the positive effect of force altering interventions in adult asthma by way of immunotherapy or what we call allergy shots. But there is yet a lot of room for improvement in gathering enough evidence as it applies to pediatric asthma. Nevertheless, a recent Cochrane database analysis of RCTs have come up with at least a moderate grade quality of evidence pointing to improved asthma symptom scores as well as decreased use of medications when immunotherapy was added. There is more evidence with the sublingual immunotherapy compared to subcutaneous immunotherapy. And I guess this is a function of the usual difficulties of conducting trials in children with these kinds of intervention. It seems you also must wait for more elegant studies that show a head-to-head comparison between sublingual immunotherapy and subcutaneous immunotherapy. So I think there's still a lot of room for studies to be conducted in this direction to supplement our overall management of our children with asthma. Now, change into a different gear, although I realized that a lot of this has also been alluded to by Dr. Melendres. I would go ahead with my additional supplement to the lecture. So let me start. Oh, yes, thank you, Emily, by the way, for that kind introduction. I forgot to mention that. And now I want to show you a picture taken a few days ago from a private island estate surrounded by pristine waters and a spoiled nature somewhere in the southern part of the Philippines. And it was at that very moment I was sitting over my lunch when suddenly I was reminded that I was a reactor for today's webinar. So I did react, okay? But what to do? Well, it was only for a moment until I realized I have to heed the call of duty and stop whining. So I put my reading glasses on, grabbed my trustworthy iMac, and got down to business. It was then that I decided a good supplement for Dr. Melendres' talk would be a reminder about must-knows in inhaler techniques for asthma patients. I realized she discussed important points, but just to reiterate, okay, it is known by a lot of us who take care of asthma patients that a significant number of them aren't using their inhalers correctly. In fact, the survey shows that about a third aren't doing it right. So this results in them not getting a full dose because it's not reaching the lungs. It either hits the back of the throat, settles on the tongue, or any other areas of the buccal mucosa. And this leads to side effects such as oral thrush or sore throat, most especially in cases when inhaled corticosteroids are used. So we have to remember that it is our duty, whether it's generalists or specialists, to remind our patients that incorrect use of inhalers reduce the benefits that they get from the drugs very significantly. Okay? There's simply no excuse for any clinician to be unaware of this important part of patient care. On the get-go, when they're first prescribed their inhalers, you must spend time to sit down with them, instruct them on proper inhaler use, and they should be reviewed on subsequent visits. It cannot just be a one-time thing. You have to allow for the so-called learning curve and make allowances for individual differences in abilities to retain the instructions that you discussed. And of course, it's always good to have a sample of the device or an empty canister, or in cases where you can't provide placebo inhalers, then that would be very, very a good tool in teaching your patients. I just there. So I think that it is very good for us practitioners to have our cheat sheets, okay, or tip sheets. This I got from the NAEPP, and you can get your own preferred sheets from any reputable source of our institutions that are used to making asthma guidelines or for treatment. But the important thing is to use these tools to discuss with the patients the steps in using their devices and their inhalers properly. And you have to give them a copy of this so that there will be that element of consistency, especially when caretakers change. For example, in the Philippines, you have yayas, and sometimes they're not the same yaya that you will see on the first visit. Okay? Now remember that the reason for going through these extra steps are common mistakes that arise, okay? And there are those that are device related. For example, for all inhalers, I will just probably repeat what was said. There are those patients who do not realize that when they don't breathe out all the air first from their lungs, there is a failure to create more space in the airways, and of course less drug reaches small airways. And those who don't know that they have to hold their breath after taking their inhaler, okay, it leads to less distribution of the drug in the places that it has to go to. So you have to tell the patients to be able to keep their airway still. Like, for example, holding their breath for 10 seconds or for as long as they can, okay, and telling them the reason why. For the press and breathe meter dose inhaler or MDI inhaler, not shaking the MDI prior to use and between puffs would lead to a failure of proper mixing of the drug components. And you know that means that the patient will not get the proper mixture of the drug. And inhaling too early before pressing the canister will not allow enough time for the patient to finish breathing in all the drug. So again, the drug ends up hitting the oral mucosa, leading to side effects as mentioned. Inhaling too late after depressing the canister, okay? So knowing that it takes only half a second to release all the drug after pressing the canister, if the patient inhales too late, he will miss out on the bulk of the drug that was released during the first part of spraying in. Okay, so again, there's a more risk of side effects. And of course, not leaving enough time between doses will not allow enough time for the drug and the propellant to mix. So you have to tell them to wait at least 30 to 60 seconds prior to the next puff to allow them also to shake it once more. Okay. So I picked this one up from the Australian Asthma book, which touched on important points regarding the use of inhaler devices in children. So just a few of the points. They mentioned for the very young, less than 4 years of age, patients less than 4 years of age, it is best to deliver inhaled medicines, the inhaled medicine via pressurized meter dose inhaler equipped with a small volume spacer and tightly fitting face mask. Now, that may not be, may seem to be a no-brainer, but what's more important to note is that it is better to use this kind of setup than nebulizer, because that's, you know, a very common thing that I see and a common practice, and I think we should realize the reason for why we prefer one system over the other. Now, with the nebulizer, I think there's a lot of wastage of the drug, as a lot of it dissipates in the environment, even with the use of the face mask. So again, you have to consider the inadequate inspiratory airflow rate in children because of their anatomy. So you have to realize that certain devices like dry powder inhalers are not fit for them, even if they can follow instructions. So it is still the MDI with a spacer that's still the way to go for these children. Now, if the child is crying, medicine will probably not reach the lower airway. And this is probably because when they cry, they take shallow, short breaths. So again, you know, they don't allow for enough expansion of the lungs, keeping the airway still. So it's probably better, if it's possible, to wait for the child to calm down before giving the inhaled medication. And we have to also not forget that when using inhaled corticosteroids, it is best, if it's much as possible, to use the mouthpiece, because when you use the nebulizer with the face mask, there's always an increased risk of exposure to the corticosteroids to the eyes and skin. Now, for those aged 6 years and over, of course, then the meter dose inhaler with the spacer is the appropriate first choice for most children, especially because they can now really follow instructions. Okay, so with a few minutes I'm given, I'm obviously not able to cover all the risks that we need to discuss with our patients. Though my main objective this afternoon is just to highlight the importance of proper instruction for inhaler use for the reasons already mentioned. I'm going to skip this. So I would just like to end my presentation by encouraging everyone to properly document treatment plans, and that was thoroughly discussed by Dr. Melendres. It's really very important in any disease, actually. So you have to document, know the diagnosis, and learn to classify by disease severity. And you have to know which type of inhaler is appropriate and document it appropriately. And also the tip sheets or the checklist that I mentioned. This has got to be written down, that you have discussed it with the patient. And of course, the details of re-instruction and rechecking on the subsequent visits have to be noted. And then if there's any reason for changing the device, you have to write it down. Okay, so that ends my short talk, and I would like to thank everyone for your attention.
Okay, thank you, Dr. Santos Ocampo, for that very extensive and clear lecture on the use of inhalers and other tips for better asthma management. So in summary, we learned a lot of things that asthma in children is common around the world, and it presents with a characteristic symptom pattern. And asthma management really aims to control symptoms and minimize further risk of future exacerbations. And it includes assessment, treatment, and review of the condition. Management includes patient education, environmental control, control of factors affecting asthma severity, and pharmacotherapy, which applied in a stepwise approach includes rescue reliever medications, controller medications, and agonists. And drugs include inhaled corticosteroids, long-acting beta agonists, and leukotriene antagonists. And of course, we cannot overemphasize that the correct use of inhalers is important in the management of asthma. We would like to acknowledge people who have written down their questions. And the first question to both our speakers is that, how long can we administer inhaled corticosteroids continuously? Dr. Melendres?
What was the question? How long?
How long can you administer it continuously?
Continuously. As long as the patient needs it, inhaled corticosteroids can be given continuously. In fact, there have been some studies showing that some children, even if they their asthma appears to be under good control, there is still some residual underlying inflammation that may be controlled with inhaled corticosteroids. So typically, as long as we make sure that we minimize side effects, that proper use of spacer is done, that inhaled corticosteroids are safe to use in the long term.
Junie?
I think I would have to agree with Cecil on that. And, knowing that it's a chronic condition, you have to make them realize that these medications were really designed for chronic use. Okay, they just have to be warned about possibilities. If they're worried about any side effects, that, to be open about it and ask their doctors so they can be explained properly.
Okay, next question is, which patients with asthma would you recommend getting a spirometry?
So we do spirometry. We do spirometry in children beginning when they're 5 years of age. And we do it regularly. We like to do it like every time they come to clinic. So at least, I guess, if for those who are not connected with pulmonary clinics or with allergy clinics, spirometry can be done as early as 5 years of age.
Okay. Question, very important here for children in remote islands who are being managed by a general practitioner. What are the characteristics of these patients wherein who should be referred already to specialists?
So it depends on, first, you can refer to a specialist if the diagnosis is uncertain, and two, if their symptoms are not well controlled. So in the step up of asthma treatment, so I believe once they reach like the step 3 or 4, wherein they're already requiring high dose steroids together with another medication, then it's probably good to refer them to a subspecialist. For further evaluation, at least for lung function testing, for checking for other comorbidities, which can be treated.
For Dr. Santos Ocampo, do pediatricians follow any local, I guess, Philippine guideline in asthma management?
I think, yes, there is, especially for the pediatric age group. And I believe this is being revised periodically. And we have a camp, it's a joint project of the Pulmonologists and the Allergologists Society that looks into the updates, revisions of guidelines. Okay. Yeah, that's our local version.
Does inhaled corticosteroids have any effect on children's growth and height? Cecil?
I'm sorry, I didn't get the question.
Does corticosteroids have any effect on children's growth and height? Inhaled ones.
Yes, the inhaled corticosteroids do have an effect on growth. So what studies have shown is that there is a decrease in growth velocity during the first year that the children are on steroids. So there's just a slowing of the increase in height. And usually the difference would be about like 1.3 centimeters. However, even if the after the first year of being on steroids, that decrease in velocity does not exist anymore, such that the adult attained height. So they've followed kids from childhood up to the time they attained adult height. They show that there's like really no significant effect on adult attained height. So yes, there may be a difference of about 1 centimeter, but that's less than an inch, I guess.
I think you have to look at it in the perspective of which do you prefer, good asthma control or half a centimeter discrepancy, which, like Dr. Melendez says, usually is countered by the growth spurt at certain points in a kid's life.
Okay, and for the last question, for leukotrienes, how long do we give these to pediatric patients?
So there's no set time that we give leukotrienes receptor antagonists for asthma. Again, it depends on your assessment of asthma control and when you can step down or step up on therapy. I'm not sure if the question is about like the viral induced wheezing, the use of leukotriene receptor antagonists for that and not on asthma. But for asthma, leukotrienes, there's no saturation, but it depends on when we can step down therapy.
On the board, we would like to just close this session and thank everybody who joined us. And after this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you as well. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. We would like to give special thanks to AstraZeneca, GSK, and Novartis for sponsoring today's webinar. Thank you for joining us. We would hope to see you again in our upcoming webinar on June 29, Wednesday, 12 to 1 p.m. Manila time with speaker again, Dr. Fatima Johanna Santos Ocampo, Joni, on early recognition of primary immunodeficiency disorders rising up to the challenge. Please invite your colleagues to join us in our continuing monthly CME webinar series. All webinar schedules and resources will be posted at www.ed/UP-webinars. In behalf of UP CM Class 1991 and the UP Medical Alumni Society, we would like to thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, DOST ASTI, and Ms. Charisse Arjalo, our host. And also, we would like to give special thanks to Philippine Daily Inquirer and the Filipino Doctor for their support as our media partners. This is Dr. Mela Lapitan together with Dr. Cecil Melendres, Dr. Joni Santos Ocampo, and the UP Med webinar team closing this session. We hope that you have learned a lot from today's webinar. Join us again on June 29. Have a great week ahead.